All right, we're on to our last speaker of the day, Dr. Chris Holsinger. I think many of you know Dr. Holsinger, but Dr. Holsinger is a professor in the Department of Otolaryngology, head and neck surgery, and a world-renowned expert in transoral robotic surgery, which we heard about from Dr. Feingersh this morning. Those of you who know Chris know he brings his A game to everything he does, sometimes a bad joke or two as well. Maybe. But we're delighted to have Chris back. It's been a couple of years where we haven't been able to get him here. And so thanks so much for coming back.
Thank you, Heather. Thanks very much. Since Heather's up here, I have to take a few minutes. Hey, wow, and I see so many people I know in the audience. Hi. We have to acknowledge and embarrass, but mainly acknowledge that this amazing woman who's put this on 6 years in a row. Every year it gets better and better, and the reach expands more and more. Heather. It's amazing. It really is amazing, and I think you make a tremendous difference in the lives of our patients and survivors and caregivers. So, man, thank you so much for doing this.
Thank you, thank you.
Yeah. Fantastic. Well, I am one of the head and neck surgeons here working closely with Heather. Oh, the other thing, too, I have to embarrass you that she has accomplished all this, everything she's done in her life without a doctoral degree. But I think next year, I think she's getting a PhD. And so we're going to, yeah, exactly. Then we'll have to call her Dr. Professor Starmer. So anyway, well, it's really a pleasure to be here, and I'm sorry I couldn't spend more time today. The program looked great, and I'm glad I got to catch Teresa's talk. We have a senior in high school, so I'm trying to maximize these last weekends together before she goes off, and well, then we'll have an empty nest. Anyway, so I'm going to talk about liquid biopsy. I think it's a huge and important part of the way we're going to treat this disease in the future. I'm not going to talk about the robot. I'm sorry, Chuck. But I will talk about, I think, a really important new way that we're going to not only initially diagnose patients, but make decisions about treatment, and then ultimately follow, as many of you are, on into survivorship, right? But it's very early days. Here are my disclosures, that are none of which are relevant to the discussion today. And in some ways, this is a futuristic talk, like a liquid biopsy. I mean, what that really means is that we maybe will never do anything else to a newly diagnosed patient other than draw their blood, which is crazy, right? And it sounds like science fiction, but even this picture, which comes directly off of, I believe it's Francis Collins' old website at the NIH, even this picture, which seems so futuristic, is from 2018. It's almost 6 years old, right? So this concept has been around forever. I guess since Star Trek, when we did the little tricorder or whatever. But we're moving from science fiction to reality, and I want to try to go over that right now in the context of HPV-related head and neck cancer. Of course, that's not all of head and neck cancers, but it sure is a lot. Many of you in the audience, both here and virtually, have been affected by this disease. I think it begins here, and this is such a great picture because, a liquid biopsy might simply be doing all diagnostic testing that we need to do with a simple blood draw. And I was amazed at how subtle, hopefully I can show this. I don't know if this goes, can you see you can't really see oh, there it is. Look at that, that needle just sort of slips in there for those of you who are a little squeamish. But the idea is the tumor sheds into an individual patient's blood, both protein that have been created by the genetic abnormalities that lead to cancer, as well as a unique fingerprint of the genes and the DNA that comprise those genes in each individual human cancer. And I think that especially for HPV, as I'm going to spend most of the time discussing, it could be a real game changer. It may be that we actually don't even need to do a fine needle aspiration biopsy of a metastatic lymph node. It may mean it'll save us from having to take a patient to the operating room simply to do a biopsy of a tumor that seems quite obvious. But we might be able to get all that information from shed proteins and DNA that have access to the systemic vasculature throughout the body. And again, it seems like science fiction, but again, even the drawing is 5 years old. And right now, we are moving quickly away from science fiction into clinical trials fact. In fact, these two trials here, one from the Royal Marsden, looking at using circulating tumor DNA or a liquid biopsy to help decide when patients with stage 1 breast cancer should get chemo. This is now almost 2 years on. And then this past year, the National Cancer Institute's NRG Oncology Group launched a similar trial using a circulating tumor DNA or liquid biopsy to help decide about chemotherapy for patients with colorectal cancer. And in our field of head and neck oncology, the amazing amount that we know about HPV, and I'm going to talk a little bit about the history of that because I think it's important for us to know, and so sort of a neat history review, is I think going to be a perfect opportunity for us. Tumors that might arise in the back of the tongue, in the way that you saw in that cartoon initially, will have access to the bloodstream, and we can actually measure the DNA within that blood. Why this is important, I'm sure someone has shown this slide, but I had to show it myself. This is a top 10 cancer now among men in the United States. More incident than pancreatic cancer, thank goodness, because that's such a horrible disease, as is head and neck. It's a top 10 cancer among men, and as you see, all head and neck cancers now comprise over 65,000, almost 67,000 patients a year, and way too many patients still succumbing to this disease. And of course, these numbers are driven by the rise in HPV-associated head and neck cancer. I'm going to talk about why that is, although many of you do know. And for those of you who haven't seen these pictures, they're curves from, 12 years ago that show this 225% increase of this disease beginning in the late 80s and moving throughout the 90s, and now in this early part of this millennia and century, the disease has continued to rise. That's the bad news. The good news is we know so much about HPV. And unlike smoking-related cancers, which we still struggle to understand, at a molecular level, the term we use and scientists use is molecular heterogeneity. The genetic defects in so many of the smoking-related cancers are so vast that scientists don't know what DNA we would measure, maybe, for certain patients who have that. But for HPV-related oropharynx cancer, we have this gentleman, Harald Zurhausen, who was a professor at Heidelberg in Germany, and he won the Nobel Prize in 2008 for his pioneering work that began in 1973, 4, or 5. I can't remember the exact year right now. That ultimately led us to basically eliminate, nearly, drastically reduce, I should say, the rates of cervical cancer in the modern Western practice of medicine among women through pap smears and other staging criteria. His work and that work of many others led us to understand the detailed biology of this double-stranded DNA virus. We don't have to go through all this. The different proteins, E6, E7, the capsid, the proteins L1 and L2. We don't have to necessarily know that. It's just important to understand that for the most common and most rapidly rising head and neck cancer, we know a tremendous amount about the genes and the DNA that cause this disease, and so it's perfectly poised for us to actually start to think about using the liquid biopsy for management of these cancers. The other thing that always, and I'll go over this again because I still talk about this with patients who are cured and new patients who are still scratching their head, how in the world is HPV related to throat cancer? It's through oral sexual practices that are very common throughout the world. And in the United States, it's estimated that 90+% of our population has been exposed in some way or another through sexual activity to HPV. Through the mouth, through the genitals, to the anal area. And so this is really a unique problem because everyone's been exposed, but yet there's, quote unquote, only about 30,000 cases a year in the head and neck. And so what's really interesting right? And I think the circulating tumor data will help us figure this out. Why is it that so many people have been exposed to this virus and so few people get the disease? Well, ultimately, it's going to be certainly an immune defect, if you want to use that word. That's a pejorative word, but there's something about in a slice of the human population, a susceptibility to chronic latent infection to HPV that ultimately, decades down the road after exposure to HPV, as all of us are in the United States, according to the CDC, leads to this cancer. But it's very odd, like, wow, everyone's been exposed to HPV, but only a few people get it, and women aren't getting it in the cervical area because of pap smears and screening, and why don't we have a screening test for head and neck? All these things really are thwarted really by the fact that we don't understand who is this little thin slice of the population that gets this disease. And then you look at this paper that's even more confusing because these are patients without cancer. There's a large-scale public health unit that we fund through the National Institutes of Health called NHANES. And epidemiologists like Dr. Gillison and Anil Chaturvedi, he was the guy who published those curves that first showed that 225% increase. They asked a simple question. Okay, sure, we all in our lifetimes, 90+% of us have been exposed to HPV, but how many are actively exposed to HPV? Do I need to worry about giving this to my partner, to my kids, to my grandkids? The answer is no. It comes back probably to this immune susceptibility. But in these data, you see that at any given time, the prevalence of oral HPV among men and women aged 14 to 69 was somewhere around 5 to 10%. And the oncogenic, the cancer-causing subtype, there's over 250 types of HPV, was only 1%. So HPV type 16 is strongly correlated with cancers. And that's only seen in about 1% of the population, right? So it's really interesting, and I'm just going to quickly show these data because I think they're really enlightening. This shows the prevalence of this disease plotted by age, and this is sort of the most granular level of detail, and this is a smooth curve that shows some really interesting findings. There seems to be a peak during our lives, early in life, probably during the greatest period of sexual activity, and then later on, around 55. I'm not implying that there is or is not a second peak of sexual activity. I'm going to stay out of that altogether there. Yeah, see, this is the bad joke that Heather alluded to earlier. So I'm going to work on my material. But it's super interesting. Is that because at age 55, when our joints start to give way? I mean, I turned 56 last year. I'm starting to see these things, right? I mean, do our immune systems change in this? In this, probably, right? Those of you who have a few years on me probably know that better than I do. But super interesting area of inquiry, and moreover, in addition to this change in the sort of phases of our lives and our age, men and women interact with this virus very differently. And therefore, you can imagine the risk category of cancer based on that interaction, based on age and gender, probably also have a big impact on who gets this cancer, right? So check this out. This is so bizarre. It just astounds me when I was putting this together this week. High-risk HPV shows that similar peak of earlier in life and late in life. Low-risk HPV that is not associated with cancer has a much smoother curve. So what is happening there? And then notice the profound difference between these peaks between men and women. And many have argued, and again, I'm a surgeon and I do other things. I'm not an expert on this at all. Many believe that exposure earlier in life really auto-immunizes women against this disease, which is why which I don't understand that, which is why this disease is most commonly seen in men. And it has to do with all of these statistics that I'm showing you here. Moreover, until we achieve near 100% vaccination, the incidence of this disease will continue to rise well past 2050. My old colleague at MD Anderson Eric Sturgis has been quoted to say, basically, we will not see a drop in those cancer rates that you saw in that early Chaturvedi paper until after the year 2060. That's the bad news. The good news is we know so much about this disease, thanks to Professor Zurhausen and all of the researchers over the years that he inspired, such that now there's a company that was licensed out of a lab at the University of North Carolina at Chapel Hill by a radiation oncologist and his PhD brother that's now working in Massachusetts, in Waltham, Mass., so that now in the blood of patients with or without cancer, tumor tissue modified HPV-NA can be reliably detected. This was launched several years ago, and based on Bisham Cher's work and Dr. Gupta, in a single institution study of only 100 patients, we really saw some remarkable correlations between the biomarker, TTMV, that they created there. It has a commercial name, but you can look that up. We're going to refer to it as TTMV. That patients who kind of had bad features at presentations, risky, adverse prognostic features at presentation, seem to have lower rates of TTMV, HPV DNA in their blood, whereas patients who had more favorable disease seem to have lower, the patients with bad features had high rates of HPV DNA, and those patients who seemed to do better had low rates of DNA. And what's really interesting to me, and I see Dr. Gensheimer here, and I don't see a medical oncologist quite yet, but for patients who initially are going to respond to radiation and chemo, which so many of our patients with HPV-related oropharynx cancer have, somewhere between the third, fourth, and fifth week before the treatment is done, the rate of tumor, HPV DNA in the blood, precipitously declines, and the rate of decline in a patient may predict long-term success for treatment with this disease. And that's what this work shows, and this is being studied more broadly beyond just this single institutional experience in Chapel Hill. Last ASCO, the biggest meeting of cancer in the world is every June, and there was one additional follow-up that used leftover samples from prospective clinical trials that patients were enrolled in nationally, HN002. Some of you may have even been in that trial here. It's a de-escalation dose, and Sue Yam, who is the director of this head and neck investigating group, is the first author. And I'm going to just to give you a little glimpse of what the future may hold for our patients in the future. As part of this study, when it launched, they started measuring blood prior to treatment, during treatment, and then after treatment. And this was done before that company that I mentioned earlier was really even founded. They had the vision, and they were aware of these new technologies around liquid biopsy. They started collecting this blood prospectively, kind of before we even knew what assay we were going to use to study it. And again, these data are not published, and this slide is super busy, but this is directly from the presentation, which is all that we have right now. The patients who were the best performing, whose disease seemed to go away fastest and most reliably, are shown here in red. And they drop most quickly when you measure before treatment and after treatment, again, illustrating that this liquid biopsy, measurable HPV DNA in the blood, when it falls, that means hopefully that our outcomes are going to be better. And so for those patients who are responding, great, but for those patients who aren't, that means we can flag those patients and maybe do better in the future with them. Of course, I'm a surgeon. I'm super interested in how this might help guide therapy. And with Sue Yam and Quinn Lee and others around the country, we are designing a clinical trial that I can't quite talk about yet today, but we will measure tumor DNA, do a liquid biopsy prior to surgery and after surgery. And if we see that there's no DNA from the HPV-related tumor in a patient's blood, we may not give that patient radiation therapy based on this assay. Is this assay good enough? these two studies that we have illustrate maybe we don't quite know that yet, and so how we design that trial needs to be done very carefully. But in a 159 patient study from Mayo and UNC, patients who after treatment had no measurable HPV DNA, based on that TTMV measure I showed you, they only recurred 3% of the time. But if a patient had surgery and radiation afterwards, and there was circulating tumor DNA after surgery and their whole treatment package with radiation, with or without chemo, they had a 22% chance of recurrence. So Dr. Feingersh was the senior author on the, who's in the back again there, was the senior author on an editorial that we published last year that says, wow, as surgeons, we really need to maybe evaluate this as a biomarker to help us select a treatment. So I'll wrap up there with a little taste of the future. As you saw, these numbers represent the significant epidemic, if you will, of HPV-related oropharynx cancer. The DNA driving that surge in cases is well studied and creates a really unique opportunity for us to really do precision oncology in head and neck, and hopefully we'll be doing this very, very soon. Thank you all very much for the opportunity to be here. Thank you, Heather.